Life with a Preterm Baby series is the result of a collaboration between clinical and institutional experts at the Canadian Association of Pediatric Health Centres, Mount Sinai Hospital, and Sunnybrook Health Sciences Centre, as well as parent-led organizations such as Life with a Baby and the Canadian Premature Babies Foundation. We would also like to thank Prolacta Bioscience for sponsoring this series. Prolacta is the pioneer of human milk-based neonatal products to meet the needs of critically ill, premature infants in the neonatal intensive care unit. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can follow CAFC and the Canadian Premature Babies Foundation on Twitter or join the conversation using the hashtag CAFCPresents or hashtag PremiPowerCanada. And for more information about premature babies, check out the Canadian Premature Babies Foundation and the Life with a Baby websites at cpbf-fbpc.org and lifewithababy.com. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CEN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive. Hello everyone, and welcome to today's webinar. I'm Doug Maynard, the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres, and it really is my pleasure to welcome you to the first episode of our 6-part series, Life with a Preterm Baby, sponsored by Prolacta Bioscience. Many of you may be familiar with our regular webinar series that we've been doing every Wednesday for the last few years. We call it CAFC Presents. And this new series has been a great opportunity to reach outside of the CAFC, well, not outside of the CAFC community, but reach across the CAFC community to collaborate with some of our partners that we've been working with on other things for many years, and to bring them into this into our webinar fold. Many of the attendees today are clinicians and administrators and researchers from the health sector that have historically been participating in our CAFC Presents webinars, but really the goal of this series is to reach outside of that clinical environment and the healthcare provider world and bring evidence and experiences to parents of preterm infants. Many of these clinicians and administrators are joining us today, but really the focus is to bring evidence to the parents of these preterm infants. So we do have lots of information on the series on the CAFC Knowledge Exchange Network for the rest of the episodes, so you can get a sense of what you can expect over the next few months. We're doing approximately one episode every month. Over Christmas we may slow down a bit, but there's lots more information still to come for each of the episodes. So be sure you sign up for the newsletter, follow the Canadian Premature Babies Foundation or CAFC on Twitter so you have that information available. So as I mentioned, the key to this session, as you saw in the intro, is the collaboration among partners from clinical organizations and family organizations, and one of the keys to this whole process has been Kate Robson. Kate Robson is the mother of 2 girls born premature, one at 25 weeks and one at 32 weeks. She spent time as a patient and a parent in 4 different hospitals and 3 different NICUs. She now works at Sunnybrook Hospital as a family support specialist, working closely with families and helping the unit deliver family-centered care. She's also the Executive Director of the Canadian Premature Babies Foundation, and she's also a member of the Canadian Family Advisory Network. So it's my pleasure to first off hand the virtual podium over to Kate Robson just to bring a few words about the series and where this came from, and to just sort of introduce this for us. So over to you, Kate.
Thank you so much. And thank you everyone for tuning in today. So I just want to take a couple of minutes to share some details about this series and how it came to be, and the Life with a Preterm Baby project, which is bigger than the webinar series. So as Doug mentioned, I work at Sunnybrook and I do stuff for the CPBF, but most important, I'm the mom of 2 children born preterm. And I was very, very lucky to have Maureen Luther at my side 11 years ago. She was the one who taught me how to understand her and how to help her. And so, just over a couple of years ago, a group of clinicians from Mount Sinai and Sunnybrook came together with NICU parents. And then we also managed to connect with a really amazing organization called Life with a Baby. And that was started by a mom to help other parents. And we were really inspired by her model. And so we created the Life with a Preterm Baby project. So we wanted to build something not just to help NICU parents in the hospital, because that's important, obviously, but really we wanted to focus on after the hospital, life after hospital as well, because we know from experience that it's very hard for families to get support and information post-discharge. when you're in the hospital, you're surrounded by experts, and then you go home and you can really feel like you're on your own. So that is a big part of this project, is to help families feel like they're not on their own. This webinar will be followed by several others, and I do want to put it on your radar. October 27th, Common Winter Illnesses, which is a terrifying but really important topic for NICU families. And in November, we'll be talking about follow-up clinics and how important they are. The other thing I wanted to mention is that Life with a Preterm Baby will be holding a conference at Mount Sinai on November 3rd for clinicians and parents, and we can share some information with you about that later. But that is enough for me. We have so much to talk about today about the building blocks of movement, and so please let me hand it over to Doug to introduce the marvelous Maureen.
All right. So today's episode is, as Kate mentioned, is titled "The Building Blocks of Movement." So it is my pleasure to introduce Maureen. Maureen is a pediatric physiotherapist in the neonatal follow-up clinic and in the neonatal intensive care at Sunnybrook Health Sciences Centre in Toronto. She has had the pleasure of working with the children and families all her professional career. Her role as a physiotherapist within the NICU and the follow-up clinic is to observe how babies and children move, from which to gain some understanding of how their brains are functioning. So just another reminder, if you do have any questions for Maureen as we go through this presentation, please don't hesitate to type them into the question box as you think of them. And without any further ado, it's my pleasure to hand the virtual podium over to Maureen Luther.
Well, thank you very much. It's a great honor to be part of this wonderful project, and I feel very honored to be the first one to kick it off. I usually introduce myself as Maureen. Hi, I'm Maureen. I'm the physiotherapist. I look at how your babies move. Babies and movement are my passion, and I've spent a lot of time watching them and trying to understand what they're actually telling us. And when we look at babies move, they are trying to talk to us. This is their way of communicating with us from the time they're in the unit and for a very long period of time. So it's taken a lot of knowledge by many, many people to try and understand what they're actually saying to us. And once we really can understand what they are actually saying to us by their movements, we can then help them. We can help them within the unit. We can help them once they head home. A big premise behind developmental care, which I'm sure everybody's heard about, developmentally supportive care, is to reduce stress. We know that the NICU can be very stressful, so our big philosophy in care for them is to reduce stress. But how do we know if they're stressed? We need to understand if they are trying to tell us if they're stressed. And movement is one of their prime ways that they can tell us, whoa, slow down, I'm stressed, this is too much, you need to help me. And so we need to do this. This is going to help their brains develop in a nice, healthy way. We all want our babies to come out of that unit with great potential and move onwards, and they're going to be healthy, happy individuals. And as well, we need to help the parents. The parents are under a tremendous amount of stress themselves. They've been separated from their babies, but they need to be able to understand how they can help their babies in a very concrete fashion in the unit and once they get home. And as they learn to understand their babies, they're going to be able to do this. They're going to be able to respond quickly and appropriately. And these are lessons that will take them lifelong. So I have a few basic building blocks to talk about as we begin so that we can understand who our babies are. And I want to say that my presentation, while I'm mainly talking about, obviously I'm talking about unit movement, I'm particularly talking about preterm babies. So it's these movements that are particularly unique to the preterm baby and what they're trying to tell us. So muscle tone is sort of the basic premise. I look at it as muscle tone as the issue about everything, but that's just my perspective. But muscle tone is the resistance of the muscles. So it's how the muscles feel and how the muscles are responding to gravity. But our preterm babies tend to be on the low tone side, the hypotonic side. And there's a range, just as there's a growth curve, there's a growth range. There's a developmental milestone range. So there's a range of hypotonia, low tone. But what we mean by low tone is that they have a little bit of a floppiness feeling to them, particularly through the arms, a little bit through the neck, through the tummy. And the smaller the babies, the lower their gestational age, the lower their birth weight, the sicker they were, the more time they spent on ventilatory support, the more time they spent on oxygen, that will make them that much more low tone. And we need to understand that so that our expectations are adjusted to that and that we don't expect things from them that they're not ready for. It will have a great impact, for instance, on feeding, which we'll talk about later. If we look at these two babies, these babies at this point are both 36 weeks of age, but they have a different appearance. This baby was actually born at 36 weeks, and he has beautiful muscle tone. Look at that beautiful belly. His arms are up towards his head. His head is almost towards midline. His legs are lifting off the surface, and this all has to do with nice, appropriate muscle tone. Our little person here, a little girl, beautiful little girl, born around 23, 24 weeks, she's a little bit more low tone. But mommy has the instinct that she needs to bring that head towards the middle. The hands are down a little bit. As mommy moves the head towards the middle, the hands come up. But you can see from the tummy, it's a little bit wide, it's a little bit floppy looking. Mommy's trying to push the legs up. So this is sort of indicative of what muscle tone looks like in a smaller preterm baby. But we need to understand that low tone, muscle tone will affect how quickly they do things, how efficient they are, their endurance. So these are things that we need to understand when it comes to muscle tone. As well, you'll hear lots of language. You'll hear people always referring to the midline. What is the midline? The midline is that imaginary line that splits the body in half. It's something that preterm babies need to work for a very long period of time. We as people, humans, are midline people. We bring everything into the midline. This is where we write. This is where we read. When we pay attention, we come to the midline. And it's muscle tone and strength that's able to bring the body to the midline. So we will spend lots of time helping the baby come to the midline. This often becomes the huge principle when it comes to positioning within the unit. So babies need to achieve the ability to bring their body to the midline. And you can see that we used a little pillow here to help this one come to the midline. So this would be considered the midline of the body. And we want both sides of the body to be operating the same way. We want symmetry. Not one side is stronger than the other in the beginning. So when we talk about movements of the preterm baby, there are basically four big schools of thought. There are four big categories of movements. There are movements that would indicate that the baby is experiencing stress. I will tell you what those look like. There are movements that indicate that the baby is in a good place. They're stable, or they're trying to soothe themselves so that they'll become stable. Unfortunately, there are movements that would indicate that the baby is experiencing pain, and we need to definitely help that. And then there are these other spontaneous movements, just spontaneous general movements, they're called. Those are the movements that the mother would feel in utero. And now when the baby's in the unit, she's not going to feel those anymore, but we want her to be able to see them, and we want to allow the baby to do them. When we look at movements that indicate stress, they tend to involve extension. They tend to be moving away from the midline. The babies are moving backwards, their hands are up, their legs are going out straight, the head and neck fall backwards, and they almost have a frozen appearance. So they arch back and they hold, and then they may collapse forward. The fingers are often a big indicator. So it's usually the fingers will pop up, go straight, and they're the first things, the first warning sign, and then they're often the last ones to fall back down into flexion. So when you see the fingers pop up, we know that, uh-oh, we need to slow down a bit, and then finally when the fingers fall back down into flexion, bend back down, then we have the sense, okay, babies move back into a good spot. As well as the face, things like yawning, staring. You may think they're looking at you, but they've gotten very starey. Gaze aversion. As babies start to get a little older, 36, 37 weeks, you start to get the sense they're starting to look towards you, but just as you look at them, they look away. And it means that, whoa, that was a bit too much, got a little bit overwhelmed there. So gaze aversion is a way of a baby trying to dampen down some of the information, trying to help themselves with stress. Frowning. These are all things that show us that the baby's experiencing some stress within the unit, and a little bit obviously beyond the unit. These are indicators that we need to help them. And then there are these movements which show us that the baby is trying to calm themselves down. These babies everything a baby does is for a reason. I wanted to say that straight out. So these babies, when they're trying to calm themselves, they're trying to get themselves into a good place, they'll pull themselves back down into flexion. And they'll pull themselves into flexion towards that midline again. And they'll grasp onto anything. Because as you grasp onto things, you get the palmar grasp, and that also promotes flexion. So they're going to grab onto that tube. They're going to grab onto that blanket. And that's a good thing because it shows that they're trying to calm themselves down, and we want to let them do it. So we don't want to be trying to pull their hands away from the tube. Make sure those tubes are well secured, and if you let them calm down and hang on to them, they're generally going to be okay with it. Let them put their hands in their mouth. Hands in the mouth is a very good thing. They've been doing that from utero, and they'll do that for a long time to be. And sucking on a pacifier. Any baby who enters a unit should have a pacifier. We need them allowed to suck on the pacifier or their hands. It has been well shown that this non-nutritive sucking is what it's called, is been shown to be very self-soothing and calming. So it's the one benefit of a pacifier. And then, unfortunately, we have things that will cause our babies pain, so things that we know would probably be quite painful. Heel pricks, suctioning, things like that. And these are movements that are generally through the face. So, and then as well as if the baby's getting ill. So things like neck, abdominal illness, things like that. If they are starting to show more movements around the face, you can see the eye squeeze, the brow bulge, this nasolabial furrow. These are all universal signs, actually, that the baby is experiencing pain. And we need, obviously, to help them here, and I will get into some strategies. But often mummies, if the babies are getting ill, they're starting to see this a little more, and they may be one of the first ones to think, something's going on here. As well, some of the body movements, so tight fisting, rapid, fast finger extension. And the other things they'll tend to do is if they're experiencing pain, they tend to bring their hands to their head, not actually to their mouth. Remember, hands to mouth is soothing, but a hand to head is more of an indication of pain. And then there are these spontaneous general movements. They're just general movements of the whole body. So it involves the head, the neck, the arms, the trunk, the legs, and they're just these nice, beautiful, random movements moving around. What you'll tend to see is you'll see them when they're sort of in an active sleep state, active alert state. They'll have a little bit of a pause, and then you'll get this little burst of movement, and they'll pause and then burst again. And we want to see these. It's a sign of good brain development, neurologically driven. There's no intention to them. And what we should see with the movements is that there's lots of variety. They keep changing over time. They're complex. What that means is they're using all parts of their body. They're trying to figure out what their body can do. So the arms will move in and out, up and down, same with the legs. And then what they're doing is they're almost building a library of movement. So they figure out, well, that my arm can do this and this. I'll put that on the shelf, and eventually, when I need to do something, I'll take that book off the shelf, and that's the movement I'm going to do. We also want, these movements tend to be very fluid and smooth, whereas the stress movements, as I said, tend to be very abrupt and frozen. So that's how we tend to see the difference. And these movements are, as a very famous neurologist said, these are the movements that are the window into the brain. We start to get a sense of how the brain is working. And so now we need to talk about the strategies that we can, once we see these movements, how can we help them, especially around the stress? We want to reduce those stress movements, and we want to promote that stability, that self-soothing movement. So positioning, number one thing, you see that in the bed space. So we position them in flexion, because remember, flexion promotes self-soothing. We want to allow the hands towards the midline, towards the mouth. And at this time, especially when the babies are younger, earlier gestational age, or they may be ill, so they're a little bit more unstable, we'll use lots of equipment to try and contain them and to promote more self-soothing and to reduce those stress movements, and we'll give them a pacifier. Now this little guy, I know that parents, one of the things when we looked at parent stressors in the unit, obviously they're huge, they're multiple, but one of the big things is that how their babies look because of all the tubes and the wires. But as nurses and clinicians, we can help them. If we look at this baby, while he does have tubes and he has a tube to help him breathe, look at how beautifully soft his face is. Look at his fingers. He's sucking on the pacifier. He's in a beautiful position here. So we know that while he is still in the unit, while he's in this isolate, while he's still he needs help with breathing, at this point in time, he's in a beautiful spot. He's nice and stable. He's in a nice sleep. He's comfortable. So this is part of his healing, his health, and he's in a good place here, and hopefully that will make the parents feel somewhat better. And then there's other positions that we'll use. Sideline is a great position to help bring the hands to the midline. The thing to watch, though, is often this upper arm. It tends to be the rogue arm. It's the arm that tends to fly backwards. So if, as parents, you come to the bedside, baby's in the isolette, and you see that arm has flown backwards, so bring it forward, bring it towards the hands, and that will help them again self-soothe. They start to be able to bring their hands to their mouth. Even this little tiny one has managed to bring the hands up to the mouth. Both hands are forward. Again, that's the midline. Prone, sleeping on tummy. It has been well shown to promote good sleep, good comfort. There's less stress movements when the babies are sleeping in prone. So prone, this sleeping in prone is used a lot at the beginning when they're younger, when they're sicker, when they're getting more support with breathing, because it's going to be better for sleep and for breathing and for comfort. But one thing to do, especially when promoting sleep on tummy, is that they're sort of up on a bit of a ledge. So we need to put a little roll under them so that they're sleeping, so that their arms and their legs are flexed down around the roll, because we want to, again, always promote flexion, and so that will, again, promote the comfort that the baby needs in this position. Other things, though, as babies start to become more stable, we start to move them out of the isolettes into cribs or cots. With increasing gestational age, we need to take away that support. We can't keep them contained up with all that equipment, because now we need to allow those spontaneous movements to occur, those nice spontaneous general movements. We need them to start practicing. Just as if they were in utero, they're constantly moving throughout their time. Now in the unit, we need to allow them to start moving around. So they're not going to be as easily stressed as they're getting older. They're not as medically unstable. So we need to let them move around and practice what they can do. But because sometimes they're still a little bit on the low tone side, a little bit weak, we need to sometimes give them some boundaries, some borders. And these nesting or the rolls will allow them to come back into the midline, get some flexion through the upper extremities and legs, and get the hands back into the mouth. So this becomes a bit of a transition when it comes to positioning. So it's a time where we've come away from that sort of that acute time. We're moving towards sleeping on the back, because by the time it's time to go home, and at least 2 weeks prior to ready to go home, we need to be sleeping, the babies need to be placed on their backs. This is going to be the position that they need to go home with. This is the safe sleep environment. So babies should be placed flat on their backs, no elevation of the bed, no blankets, no swaddling, no pillows, and the babies are put here to sleep, and they should have at least 2 weeks practice before ready to go home. And plus as well, at this point in time, they're probably starting, they would be, if they're getting ready to go home, they're starting to rouse up more often to feed. So they're starting to respond more frequently to their hunger cues. But if you're all wrapped up and swaddled up and you have a lot of blankets on you, how can you start to wake up? How can you start to move around, get those nice spontaneous movements, which will also start rousing you up and getting you prepared to eat? So we need that to happen as we start getting them ready for home. As well, then, handling, which happens very frequently to our babies, and sometimes it's the handling that can really set off those stress movements. So we want, as we have to handle them, we want to try and use nice, gentle hands, 2 hands down on the baby, stopping those stress movements. And there's now becoming a movement where we have 2-person care. So the nurse has to do her care. She has to do it efficiently. She has to do it well. But maybe mommy could provide another set of hands to help calm the baby. So we have 1 pair of hands that are doing the work, and the other hands that are there to contain and help, and therefore reduce the stress for the baby. Slow, gentle movements will also reduce the stress movements, and again, always promoting flexion, especially as we're starting to pick the baby up. Don't let the head drop down, and scoop the head up, scoop the bum up, and then that will give flexion, and that stops that falling back into extension. So just as you're about to move them, you haven't set them off, and they're now stressed as you start to handle them. And of course, the most important thing that will reduce stress and promote stability for a baby is that parent touch. Babies learn from their senses. So that's how babies are aware of what's going on around them. They're aware of what's touching them, what they smell, what they feel their movements, and parents represent to this baby a consistent package of senses that comes every day. They smell the same, they taste the same, they move the same, they sound the same, they move them, they touch them, always the same. And for them, this is a consistent package, and it starts to take away some of that stress. The babies are able to have an association with this package of senses that comes every day, takes away the stress, and helps me calm down. And so it's very important that the parents are there and that we allow them to touch their babies and handle their babies. If the babies, as in the top here, maybe is still a little unstable, can't come out of the isolette, then mommy's going to come in and do a hand hug. She's going to talk to her baby, gentle pressure on the top of the head, gentle pressure on the bum, and those are things that are going to calm the baby, and he's going to feel and start to get the sense that she's there. Or as well, we're going to do things like modified skin-to-skin. Baby is still unwell to maybe come out. The transfer often can be very stressful. So we're going to help mom set mommy up so she can do it. It's so beneficial for mommy and baby, and it has been well shown that a lot of the stress signs will go away with this kind of time together. Skin-to-skin. There's nothing better for a baby. It has been well documented in the literature that skin-to-skin will reduce stress movements, will reduce some of those autonomic physiological stress signs that increase heart rate, DSATs, things like that, bradycardic events. So skin-to-skin are a great time. They need to be together. As one dad said, kangaroo care is crucial for the babies to grow and develop, and medicine for the parents. There was recently a study showed that babies who experienced skin-to-skin had a better ability to regulate themselves, to control their own stress, had better sleep, and that even at 10 years of age, the benefits from skin-to-skin were apparent in school. When we look at the babies doing skin-to-skin, they are definitely sleeping better. So the only advice for the parents would be prepared to at least do an hour and a half of skin-to-skin, because often it's the transfer that can be the most stressful. You're going to see a lot of stress movements at that point. So we want to get them out, get them on the chest, get mommy comfortable sitting down, and then hopefully at least an hour to an hour and a half, because that's generally a sleep cycle. If more, all the better, and there is no detriment for the baby in terms of that. The nurses are going to be close by. If things start to happen, then they'll move them back. Feeding. Feeding has its own set of movements. And in actual fact, the whole trend right now in the unit is towards what's called infant-driven feeding. And basically, infant-driven feeding is reacting and responding to the baby's movements around feeding. So first of all, we have feeding, what we call readiness cues, a whole set of movements that will tell the caregivers, the mommy, hey, I'm ready to feed, I'm hungry. So you start to see the head moving side to side. You've got a rooting, the mouth is reacting, the hands are coming up tight towards the midline, up towards the mouth. There's this whole group of movements that show that the baby is starting to wake up, they're hungry, and they're ready to feed. So that's when we start to feed. We don't feed just because it's Q3 and it's on according to my schedule. We want to feed according to what the baby is telling us. And then as the baby starts to feed, I've shown a bottle here. Obviously, breast is best. But as the baby is feeding, she should look very comfortable. Nice soft face, nice open eyes, sucking away with a rhythm, nice gentle hands. So there's nothing about this baby that shows that there's any stress. So this baby is stable and he is absolutely ready to feed. And we respond to these cues. We keep going. But then we have cues that start to tell us, whoa, slow down. Again, there's those fingers. They're starting to pop up. So it's like the yellow light of the stoplights. It's like, whoa, slow down. I need some pacing. Take the bottle out of my mouth. I've got a little bit of a furrow here. I might start to blink. I might get a little bit of nasal flaring. I might start pulling back ever so gently. It's very important to respond to these cues. Bedside nurses, caregivers, we need to teach their mothers that this is what our babies are trying to tell us. Responding to the cues and these early stages of feeding will take her forever. These are lifelong cues that we all need to understand what our babies and what our children are trying to tell us. And then we have these very definitive skills, these very what we call potent disengagements. Whoa, I am done. I've pulled right back. I'm falling asleep. I'm yawning. And so I'm really telling you, stop feeding me. And it's these movements that tell us what the baby is trying to say to us. And it's very important that we learn to respond to them right from the very beginning. And then there's pain management. Unfortunately, our babies do have painful procedures in the unit, so we need to be able to respond and help them. There is pharmacological management. Of course, the medical team will take care of that and choose the right medications, but there's also things called non-pharmacological pain management. Things like non-nutritive sucking, sucking on that pacifier. You'll hear the nurses talking about sucking on the pacifier, non-nutritive sucking, and using sucrose. It's got some sugar in it. It's been shown, well documented, that it helps pain. So it's a little bit of sugar in the mouth. It goes into the cheek area, and it helps diminish the pain while the baby's sucking on the pacifier. As well, skin to skin during a painful procedure, things like a heel prick, things like that, has been shown to reduce the pain for the babies. Breastfeeding, it's actually sucking, getting some breast milk. Breast milk is a little bit sweet, so this will help pain. Positioning with containment, using equipment, or best of all, using mommy, her other hands. Can she help the baby through that painful procedure? Good pressure, it's called facilitated tuck. Nice pressure on the head, nice pressure on the bum, help contain the baby while the painful procedure has to be done. We want to help the baby diminish the impact of the pain, and we want mommy to be there to help. So then there are things in the unit that sort of looking at some developmental strategies, and we all start to be aware of, with the positioning, the babies start to get this long, thin head. It comes from weight bearing, both on sideline and when sleeping on tummy, but I want to assure you that this will change. The skull is very malleable, and it will change over that whole first year, up until at least 12 to 15 months post-term. So you will see this long, thin head in the beginning. What we do want, though, is equal weight bearing on both sides of the head. So we tend to face the babies more to the right, and this tends to get a little bit more pressure on the right side of the head. This right-facing preference is a very common thing within the unit. It comes because most of us as caregivers are right-handed. 80% of the population is right-handed. So we tend to set the babies up so all the lights and the action are happening to the right. It helps the nurses be more efficient. They need to be able to come in quickly, do what they need to do. And so that's why they tend to get set up facing out to the right. But while the babies are in the isolette, we can get mommy to come around to the left side of the isolette, and maybe she can approach the baby from the left. He hears her voice, and that's going to alert him to try and turn towards the left. Once the baby is stable, because there's usually equipment that drives the nurses coming from the right, and we can't alternate the head or putting the baby at one end to the other. So once the baby comes out of the isolette, maybe into the cot or a crib, and they're not as so dependent on some of that equipment, it's just oxygen maybe, then we can start to move the baby from one end of the bed to the other end. And so that we want to also alert the baby when we come from his left side, so that he starts to turn towards his left. Remember what I said, we want the baby to be symmetrical, so it can look one way and the other way. So, but ultimately we want to really promote midline. So even in the unit, we're going to start doing this. So I usually recommend that once the baby is sort of in a crib bed space or a cot bed space, that the mummies and the nurses, the caregivers, should be approaching the baby from the midline. So if you need to, you can use a pillow, you can use a roll to support the baby so that the baby can start to bring his head towards the middle. If you're doing your care in the middle as you're talking, the baby will alert and start to try and move his head towards the middle and try and then start to be able to look towards you. And so this starts to promote this midline even from a very early age within the unit. Our babies, because they're a little bit on the weak side, they tend to have what we call weak pecs, the pectoralis muscles, as I pointed out here, and the weak abs. So it's the pecs and the abs. So they tend to be very weak. They're very strong in the back because these muscles are weak, and so they tend to pull back more through the back muscles. And this is something that we're going to be working on for at least the first 4 to 6 months as we head home. But in the unit, we also want to start trying to work on them, and we can begin a little bit of tummy time at this point in time. I'm going to review a little bit of the tummy exercises and some of the exercises for the pecs. These exercises can be done as the baby starts to transition more and more to supine. The problem, and it also becomes good to do some of the tummy exercises because you often hear about how the babies are having difficulty passing gas, stooling, things like that, and that often generally has to do with the weak abdominal muscles. You need strong abs to be able to evacuate, to push out the gas, to be able to stool. So the effects of those weak abdominal muscles are even impacting on the baby at this point in time. So in this picture, if we spread our hands, put them over the baby's tummy muscles, we tend to capture then all of the tummy muscles, and with a gentle squeeze of the fingertips, bring the fingertips together, you'll feel the tummy muscles tighten underneath the hand, and you'll actually see the legs lift up. So a couple of times you do that, every diaper change will start to strengthen the tummy muscles. And then down here, same thing, put your fingers on those pecs where the X's are, and squeeze your fingers together, and you'll see the arms come up together. So that starts the beginning of trying to strengthen these tummy muscles. As I said, you can start some tummy time, but you have to have a balance here because babies are also trying to work on feeding. So if feeding is at this point still very hard work, we might leave the tummy time for a little bit closer to discharge. But as the feeding starts to become a little better and we're wanting them to start to rouse up more frequently, we can use tummy time as a bit of exercise to start rousing the baby up, getting them awake, help them work a little bit, help them exercise their abs and their pecs, and then they'll start to participate a little bit more and start helping feeding. The low tone will also have some effect on their feeding abilities. So it's that feeding is like running a marathon. So they have to be able to feed every 2 or 3 hours throughout the day, 8 times a day, day in, day out. And it's often that muscle tone that is impacting on it and making it difficult. So the stronger we make the truncal muscles, the better the suck will be, the better the suction will be, and it will help overall feeding. And then finally, it's time to go home. So a very important thing to understand once you head home is this concept of corrected age. Corrected age is from the time the baby should have been born. It's that due date. But it's also important to understand that that's the brain age. If the baby is born at 27 weeks, the baby's brain is 27 weeks of age. At 40 weeks, the baby's brain is 40 weeks. It's term. And it's from there that we sort of begin to count. How the baby moves, how the baby feeds, how the baby grows, the weight will all be dependent on that corrected age. So for instance, the first time that we see a baby in neonatal follow-up clinics is 6 weeks corrected age. So the baby may be 4 or 5 months of age, but in actual fact, he is functioning like a 6-week-old baby. I usually recommend to families, when you're out and about, always give the corrected age. Otherwise, people may make comments that they have no right making a comment, but your baby will look like the corrected age. The only thing that won't go by corrected age is the immunizations. Going home, you should understand what safe sleep environment is. I talked about that, flat on the back, never sleeping on tummy, never swaddling, don't use blankets, don't elevate. Those are all things that are very important for a very safe sleep environment. You should have a feeding plan. You'll know how you're going to feed your baby. You'll understand the cues of how to feed your baby. If there's certain things that will need a transition, you'll know when that's going to be changing. Say you're using a preemie nipple, will you know who's going to help you change to maybe a faster flowing nipple? Or if you have a certain position that you're feeding a baby, do you know when you're going to change it or if you need to change it? And then once we leave the unit, while in the unit, our big philosophy is reduce stress. And now once you head home, once the baby reaches term, now we can start pushing a little bit for motor development and overall development. So now comes the big push. So what we tend to see sometimes is this residual of this right-facing preference that we talked about. It comes from the unit. It comes from how we set them up. But now we start to have this impact of what it could mean if this baby has the preference of facing right. So what tends to happen is the baby is consistently facing to the right. This muscle here in the neck, which you can see here, it's the neck. So this lady is looking towards her left hand. This muscle is on the right side of her neck. So it's this muscle that starts to get very strong if you're always looking one way more than the other. So what we need to do is counterbalance that and get the muscle on the opposite side of the neck to turn the head the other way. So as I said, babies tend to look more to the right. It's the muscle on the left side of the neck that turns the head to the right. We need to get the muscle on the right side of the neck to turn to the left. As well, if we consistently have a baby who's looking more one way than the other, it starts to change the shape of the skull. Just as when they were sleeping on their sides and on their backs, they had a change of the skull shape. Now, as they start to move and sleep on their backs, they're going to change their skull shape again. And if we let this facing preference go on too long, that muscle can start to get a little tight and it can start to tilt the head, and then we can potentially get what's called a torticollis. But with early work, early awareness, this will not happen. So when I talked about that skull shape, we tend to get sort of this flattening to one side of the skull. And if you look down from the top of the head, you can see how the skull is starting to shape because of this right-facing preference. So you want to actively getting the baby turning to the left side. So when changing the diaper, you're in the midline, or you may be just left of the midline. So you're getting them to look at you, and especially as they start to achieve eye contact, which will start to come around about the 6-week mark. Then you can really start getting them to look at you, and that will really help them start to turn one way and the other. Or a sleep strategy. Just as we place them in the unit facing to the right, you're going to put them in the unit, or put them in their bed at home, so that as you approach them, they have to turn to their left. So again, you want to balance this out, and being proactive very early will prevent a lot of these issues. But one thing to remember, that with this right-facing preference, putting them in seats, so infant seats, car seats, bouncy seats, that will not help the head turning. So it tends to promote the persistent facing, so that persistent right facing, for instance, and again, it tends to promote that flattening of the head. So because once a baby's in a little seat, they can't move around as easily. So limited use of these seating systems, the swings, things like that. The babies need to be able to move around freely, turning their heads from right to left. So all these seats and car seats do not help this situation. If you find that you do have some persistent right facing, then a little exercise you can do is, so you have persistent right facing, you're going to lay the baby on the left side, gently hold the head down, and let the body fall back. Babies don't like you to move their heads around. They'll just fight with you. So if you let their body fall back and put a little pressure on their right shoulder, that will start to stretch their neck, and then you can talk to them on the left side, and it tends to be a very effective way to get them to look to the left. Head in the midline, again, it's a big goal. We want them to start to do this on their own. As I said, it promotes symmetry, but they need trunk strength. They need those abs and those pecs, believe it or not, to bring the head to the midline. The trunk is the control center, and it is what the head, the arms, and the legs move off of. As they start to bring their head into the midline, this is when they can achieve eye contact. And this will also help their skull to start to round out. I've placed my hands on the baby's trunk, gives the baby added control and support through the trunk, and they are able to bring their head into the midline all on their own. Eye contact. It's a beautiful thing. This eye contact begins to show the baby is attentive, learning. This baby is looking at us, and this is a learning moment. He is in that quiet, alert state. It's like a flower that's opened up, and he's taking in all the information of his mummy. So it's the beginnings of cognition and language. As the baby is attentive, he's watching his mummy, he's taking in the information, and it's the beginnings of language. It's that turn-taking. You want to be able, as your baby starts to look at you, you're going to keep your face calm. As he can look at you a little longer, then you may smile. You'll add the smile. You can add your voice, and then you can add your movement. If the baby's looking at you and you smile and talk and they look away, it's just that, whoa, it's a little bit too much. They want to look at you, but you overwhelm them a little bit. So gaze aversion, as I said, it's too much information. Just back it down, and they'll come back to you. Anti-gravity. So work those abs. So on their backs, we want the babies to start lifting their legs. That's showing that they're working their abs. The higher the legs are getting, the stronger the abs are getting. And hands to mouth is a very important thing. Hands to mouth is a very important milestone, so no mittens. Even if you are starting to get some scratching, we don't want to cover the hands. That's just how babies learn about their hands. Their hands are very important tools. They're working their abs as they're working their pecs now as they bring their hands to their mouth, bring their hands to their feet, and they're also preparing their mouth for feeding. So when it's time to start putting the spoon in there with some solids later on. So it's a very important thing that they can lift their legs, get their hands in their mouth, and eventually actually put your foot in your mouth. It's your one time in your life where it's actually cute when your foot's in your mouth. So, tummy time. Tummy time, tummy time. So, when awake, it's very important to get the baby on the tummy. This is the one foolproof way to strengthen the abs and strengthen the pecs. And it's from being on the tummy that babies start to move. This is where they move from. They don't move on their backs. They move on their tummies. This is how they can see and explore their environment. So, our one suggestion I'll talk about, and this is our strategy. So when put on the tummy, when awake, we want it to make a time where they're actually going to work. So it's not just lying on their tummy and their face is sort of digging into the ground and they're not really being effective. So I usually suggest put some pressure down on the bum with your arm and help the elbows stay in front of the shoulders. By putting some pressure on the bum, it helps lift the head, so you've shifted the weight off the face down towards the bum, so it becomes the stable point. And by keeping the elbows in front of the shoulders here, this will ensure that the pecs are working and that they're weight bearing through their arms. And now we're actually going to get the baby where his head lifts, he's working his tummy muscles, he's working his shoulder muscles, and you'll probably hear him, and so that really shows that he's working hard. So our rules are short and frequent, so lots of opportunities. Every diaper change, 8-10 times a day. Get them over on their tummy, 1 to 2 minutes. Rest your arm on their bum. Keep their elbows forward. Let them work. And if you do it short and frequent, then they won't be so upset with it. You may get a little fussing, but you're over quickly. If you're doing it several times in the day, this will help build their tolerance. And then once they start to become more tolerant, it's not so stressful, then you'll do longer and longer. The other thing is always best on the floor. You need that firm surface to work off. So not on a bed, not on the couch, not on a change table, but down on the floor. The floor is the safest place to be. And it's the easiest place, that firm surface is the easiest place to lift your head and work. And always doing tummy time when awake. Never doing tummy time or allowing a baby to sleep on their tummy. So another sort of basic building block of movement, I talked about that low tone, I talked about that midline. The other basic important building block is movement is about weight shifting. So when they're on their backs, they are actually shifting their weight from their tail to their head. And so that's why we want to encourage those legs are up. They need to start shifting their weight around. On their tummy, they're shifting their weight from their head to their tail. And then on their tummy, they begin to learn to shift from side to side. So as they're starting to tolerate being on their tummy, one toy on the right hand, another toy on the left hand, and they start to shift as they look from toy to toy. And this is what's going to promote movement. They need to shift their weight down their body and then from side to side. So simple, basic premises will start to facilitate movement later on. And a very important thing, I've talked about it over and over, is babies, we need to build the strength of their arms. Babies use their arms in that first year for movement. Everything they do with movement is using their arms. So again, that's why tummy time is so important. We don't want to get into promoting sitting before we have that tolerance of tummy time, because it's using your arms that's going to facilitate all that movement in that first year. So we need that weight bearing that's going to get their arms stronger. And while they use their arms for movement in their first year, after that, as they've built that strength in their arms, it's going to help later on when it comes to their fine motor skills, their hand skills. Those teachers who write on the blackboard, they have strong shoulders because they can keep their arms up in the air and write on the chalkboard. So we want good fine motor skills later on, and we can do that even in this first year as we build the shoulder strength. So again, tummy time, tummy time. It has been shown in studies that the more time they spend on their tummy, and I don't want to sound, boring in this one, but the more time they spend on their tummy, the better their motor skills will be. And tummy time, playing, and moving around should always be on the floor. You can never fall off the floor. So no promoting movement or tummy time on the bed, the couch, or anything like that. Always down on the floor. It's safer, and stay out of the plastic containers. Exercisers, jolly jumpers do not promote good normal motor development. They actually end up feeding into that back extension that we talked about. They promote stiff legs, they promote toe pointing, and they will not help movement, and they will not help get the abdominal muscle strength nor those arms to be stronger. What really helps motor development and movement is that ability to move freely around on the floor, using your arms, using your abdominal muscles. This type of thing helps overall cognition, it helps overall social skills, language, everything. Motor is the key to development, especially in that first year. And the other thing is there's no need to play in standing. A baby will pull to stand using his abdominals, using his arms when he's ready. So there's no benefit putting the baby up and standing and trying to walk them around. They will get there when they're ready. And finally, at 1 year corrected, we hope to see our babies up, standing independently. And this is a beautiful baby, a graduate of our unit, and she's so gorgeous. So thank you very much. Are there questions?
All right, thank you, Maureen. What a fantastic presentation and a real pile of information there. So fortunately, as I mentioned earlier, we are recording the session. I'm sure everyone will want to go back and sort of refresh on a few of those things because there's a lot of great information there. We did have some questions that go way back, and that's once again, remind the audience, if you do have any questions, please type them in. We do have about 8 minutes of our scheduled time to answer some questions. The first question came back way back near the beginning, and it's from Carrie, and she's asking, you were talking a lot about hands to the midline, hands up to the mouth, etc. A lot of pictures of the babies in the NICU with, in most cases, nasal CPAP on. But are you worried about those that are intubated, promoting that hands to the mouth when they're intubated? Are you worried about self-extubation, etc., or how do you manage that?
No, I don't. We should not worry about that. I think that if and even our respiratory therapists will say, if those tubes are well secured, then we should be able to allow that baby to come towards the tubes. So secure the tubing, secure the intubation tubes, but allow them to come towards that midline. Now, if the baby grasps on and you want to get their hand off, what we always tend to do is put our hands in their palm and trying to let them pry their fingers open. But by you putting your hands in the baby's palm, you end up eliciting that grasp reflex even stronger. So if you want them to let go of the tubes, stroke the tops of their hands, and that will promote their fingers to open up and extend, because that's where your extensor muscles are. So you want them to be calm, and then they won't pull on the tube if they have their hands to the midline. Does that answer it?
Yeah, no, I think that answers it very well. Yeah.
Okay.
As a former respiratory therapist, it does make me a little bit nervous, though, but I'll trust you when you say just secure it properly and it'll be fine. The next question came in was from Christine. She's asking, at what age is it okay to start tummy time?
I mean, we should be starting as it's a little bit of judgment. So definitely by the time they're ready to go home, for sure they should be doing tummy time. So once those babies are heading home, and if they're heading home around term, then they should be doing tummy time. For the stable babies who are starting to feed, ad lib every 3 hours or whatever, they're nice and stable. And if that's 38 weeks, 37 weeks, then I would be doing tummy time then too. So the only way that there would be any sort of contraindication to tummy time and making them work is if it's really fatiguing them, and then they can't from there try and go and feed. So, but there's nothing wrong with doing tummy time. As long as they're alert and they're sort of wiggling around, then you want to promote it.
All right. You mentioned the elongated head. That's perfectly normal, and the head's malleable, and it will eventually recover. How long does it usually take to recover before someone should maybe start to be concerned about it? Like, sort of, how long will it should parents not worry about it before they may want to bring it to the attention of of one of their healthcare providers?
Okay, so the elongated head will start to change because of the back to sleep. So once the babies start going back to sleep, then you get the change from the long, thin head, and what we tend to find, then you start getting the flattening on one side. So you do want to see it starting to round out around 4 to 5 months post-term. If you're having some significant where there is no change to the skull shape and there is significant sort of deviance to the skull shape, that's probably not the right word, but then we can refer around the 6-month mark to sick kids for them to evaluate the skull shape. But I think with good preventative care, good promoting movement around tummy time, you should start getting some changing of the head shape 4 months at the latest.
All right. For this next question, we're going to go back to the tummy time.
Yep.
Beth is saying her son is 10 months, 6.5 months adjusted.
Okay.
She says he hates tummy time and will roll over immediately. How can she keep him on his belly?
So, over on the tummy, try and get down there, and you've got your hand on his bum, so you're sort of keeping him stable on his bum so he doesn't flip. And the other thing too is probably what he's doing is he's losing his balance, so he's sort of flipping off to one side and then moves the head, and that flips him over. So she wants to keep him stable, equal on his bum, so both hips are flat on the ground. She can do that with her hand, and again have two interesting toys. So if he tends to look more to one side and that sends him over, if he looks more to the right and that sends him over the left side, she's got a super interesting toy, mirror, her face on the opposite side, so that he's starting to shift his weight from side to side. So if he prefers to look to the right, she's going to put the toy to the left, so that'll start shifting his weight onto his right side. And again, short but frequent. Like, and now once you start getting to that point, he should be down on his tummy practicing every half hour that he's been awake. So and as they tolerate tummy time as infants, the more and more they get down on the floor on their tummy, the better things will be.
And sort of similarly with the back to sleep, so the opposite. So if you're putting them back to sleep and they don't want to stay on their back, is it more about sort of using pillows or whatever to prop them, to keep them on their back, or do you just put them to sleep, and if they choose to roll over at some point during their nap, you let them roll over, or do you try to force them to sleep?
Okay, once a baby can roll over onto their tummy, then we can let them sleep on their tummy. But until the baby can roll over and get on the tummy by themselves, we have to leave them flat on their backs, and there should be no rolls, no blankets, no positioning devices to keep them on their backs. I think some of the thoughts with this whole back to sleep campaign is that, yes, when they're sleeping on their backs, they tend to startle and wake themselves up every 60 to 90 minutes, and that's what's supposed to happen because they're going to get a couple of sleep cycles, and then they're going to wake themselves up because they should get up and feed. Sleeping on tummy promotes too deep a sleep, and that's the worry, is that if they're in too deep a sleep, that they might not wake up. So they need to be on their back, and they will startle, and that's what does wake them up, which is what they're supposed to do. But no putting to sleep on tummy for sleep, or no putting on their tummy for sleeping until they put themselves there.
Right. You mentioned a couple of times, and even in the questions we've seen of people using the corrected age. Up until what age do you use the corrected age when you're speaking with your practitioners?
So presently in our neonatal follow-up, we use it until 3 years of age. We correct until 3. There's some conversation even out there to go a little longer, but generally it's till 3 years of age.
Okay. Summer is saying that she's seen some research that suggests we should be using adjusting age we should be adjusting age at a more 3-to-1 ratio rather than a 1-to-1 ratio. For example, 3 days in the NICU to make up for 1 day of utero development. Have you heard about that, or do you just typically just a 1-to-1 sort of day-for-day adjustment?
No, I haven't heard the 3-to-1. It's just generally it goes according to when they should have been born, because it's sort of how you're looking at the development of the brain.
Yeah. Okay.
So I'm not aware of time in the NICU, how that affects anything.
Yeah. Okay. All right. Thank you. We are.
Kate wants to respond to that.
Sure, absolutely. Go ahead, Kate. Yeah.
I haven't heard specifically of that, although it would be really interesting to read if there's been any research done in that area. I do think what some people refer to is that if you've had a very early baby, i.e. a 23, 24, 25-week baby, so for example, my 25-weeker, she stayed in hospital and she needed care until she was about 44 weeks, i.e. 4 weeks past her due date. So it is true that if you were born very early, sometimes you need a little bit of extra time to catch up. But I don't think there's a formula that we can really attach to that. With good developmental care, and if the baby has a relatively smooth ride in the NICU, I've seen 23, 24, 25 weekers going home at due date and meeting those milestones according to their corrected age. So yes, the impact can be the burden of the NICU can fall a bit more on the shoulders of babies who were very, very preterm, but it's not always the case.
And often it's that low muscle tone that impacts. The younger they were, the more low tone. And so that affects sort of their development, their sort of outward motor development. But in a neonatal follow-up, we certainly understand that. I guess it's that sort of underlying understanding of what the baby is doing and our expectations. But the corrected age is sort of based on that brain development.
All right. We are past our scheduled closing time. We will take a few more questions just to sort of try and wrap up the majority of the questions that we're getting in here. So if you do have a real poignant question that you'd like to make sure you get in, please do make sure you type it in quickly. Amber just put in a comment related to the corrected age. She says, remember that developmental milestone acquisition is a wide range in terms of when even term babies develop skills. So
exactly.
Certainly pointing that out.
Yeah.
Joan is saying she's wondering about the necessity of making sure that babies are not being swaddled to sleep before discharge. As long as the baby is not rolling, is it not okay for the swaddling for sleep okay?
No. So it's definitely the new sort of guidelines, especially coming from the College of Nurses, is that they're recommending not to swaddle. Swaddling is presenting a bit of a risk. So first of all, swaddling will inhibit the moro, and as I said, or that startling, and as I said, the sleeping on back, the startling reflex is there for a reason. It kind of keeps the baby going. It brings the baby alert, and it prevents that too deep a sleep in a very immature baby. As well, swaddling involves blankets, and blankets themselves can become a risk. They can become a suffocation risk. And so they also shouldn't be there. And then the other thing is there's a lot of differences in terms of understanding of how to swaddle a baby. So you see that on the internet all the time. And the nurses, they're the best swaddlers there is. They'll get the arms down by the side, they'll wrap them up snug, and sometimes in the unit that may be necessary, but not once the baby's head home. So it should not be part of the safe sleep environment.
All right. This next question is asking about again back to the tummy time, but this time any suggestion or recommendations, guidelines for babies with trachs and or G tubes and how they can get tummy time, or any suggestions for that?
We still need to do it. With a trach, what I've done there is give them a little bit of an elevation. So under the chest, so you're sort of going to elevate the chest up a little bit. You want them weight-bearing on their arms, but you also have to clear the trach. So you do want to watch that. With G-tubes, technically you should be able to weight bear on them, and you do want pressure across there. If they can't go on that one side, then it needs to be looked at. But there shouldn't be, you should not promote tummy time because it's going to impact their overall development. So you do want to do it.
All right. A number of questions, people saying that they do have to leave right now, but asking if the slides will be made available. I know you have lots of pictures in there, so it's always a concern as to whether you can share a copy. But, okay, then we will post a PDF of the slideshow on the Knowledge Exchange Network, where we post the recording for all of those of you who are asking before you leave. Amber is saying that she says excellent presentation. She really likes the continuity from being in the NICU and beyond, so that you talked about today. She's asking, does your NICU or neonatal follow-up have transitional support for families around discharge home? And what does that support look like?
Well, we do in a sense. We could always be better. But myself personally, so I work in the NICU and I work in neonatal follow-up. A nurse practitioner does the same, and our 2 developmental peds neonatologists also do the same. So we kind of help with that. We also have a very early initial visit in our neonatal follow-up. So our first visit is generally like 6 weeks corrected. For some babies, they may have only been home a week or 2 before they're back to follow-up. Or there may be others who have gone home a month or 2 before that. But I think follow-up should have, I think one of the most important visits of follow-up is that initial early visit. So now 80% of our babies get retro-transferred out of our unit. But for those babies who stay, I think there is pretty good transition for our babies from the unit to our follow-up.
All right. Well, I think
Sorry, I just want to jump in. Something that we've been working on, and we're not anywhere close to launching, but I think it's a really great idea, and I think other people across the country are way ahead of us on this. But is working on something, we called it here a bridge program, but the idea of doing a outreach with families after they go home, so that we can check on them in their homes, see how they're doing. I think that's happening out west. I think there's some really great work in this country on that, and I think I sort of issue that as a challenge to a lot of follow-up clinics and NICUs. There's that time of, there's that period of time between going home and when you're seen again by follow-up, and right now for a lot of families that feels like a wasteland. And we really need to do something about that.
Thanks for that, Kate. Transition is so important. I know CAFC does talk a lot about that with respect to transition to adult services, but all transitions are difficult, and lots of things can fall through the cracks. So absolutely, I hope everyone sort of takes every opportunity to address these points of transition, whether it's the NICU to home or back to the follow-up clinic and all that. So thanks for that comment. All right, I think with that, there's lots of other comments and stuff coming through, quite a bit of activity, but I think we should wrap this up now. We are quite a bit over our time. I did want to give both Maureen and Kate just an opportunity for some final comments. So Maureen, any closing messages or final comments you'd like to give? Any resources, any place? We've talked about the Canadian Premature Babies Foundation and the Life with a Baby websites. Are there any other websites or anything that you'd like to just leave the audience with for them to get more information?
Well, the only one I can think of quickly off the top of my head is Sunnybrook has some videos or some websites. It has a website, and on that is the tummy time that we did, Kate and I, and a couple of beautiful little babies, and it sort of reviews how to promote tummy time and that eye contact. So I guess I can't stress enough how important it is, and I think our babies do quite well because we've been very vigilant about that. And that's all I have to say. I don't know.
Thank you very much. And Kate, anything else? This has been such a great presentation, and thanks again to you for sort of leading this off and really working with us to bring such great content. Yeah, anything else you'd like to add before we close off?
Well, thank you for the opportunity, and it's a pleasure to work with you as always. I love the idea that, we're working together, parents and clinicians, to create informational resources for parents and clinicians. The idea is that, if we work together, this is the best way to empower parents and caregivers to take care of these amazing babies. And the last thing I'll say is, and I've been doing this for 11 years, but you can never go wrong listening to Maureen.
Thanks. That's only reinforcing me.
It's Elaine, Maureen, and Kate. I just want to say what a fantastic presentation. Thank you to you both.
Thank you very much.
All right. Well, my thanks as well to Elaine and Maureen and to the rest of the audience for all of your great conversation and questions and comments and everything else that you put in. We are doing these webinars approximately once a month, so be sure to sign up for the email newsletter that we mentioned. You can find that on the CAFC website, the CAFC Presents email newsletter, as we are promoting these webinars, this webinar series, along with our regular Wednesday webinar series in those newsletters. Or you can always follow CAFC or the Canadian Premature Babies Foundation on Twitter so that you can keep up to date for the next episodes, or just keep an eye on the Knowledge Exchange Network. There is a page on the Knowledge Exchange Network for the series that lists the dates for all 6 episodes, and again, we'll be putting the links to the recordings and PowerPoint presentations and everything else up on the Knowledge Exchange Network so that you can go back and refresh on anything that you might have missed, and of course share with all of your colleagues or friends or family or anyone else that you want to share this with. Please don't hesitate to share it as wide and as far as you can. So thanks again to the audience for coming. Your questions and comments really enrich the discussion and make it interesting. But when you can't watch live, as I mentioned, just go back and check out those recordings if you can. The next episode, as I mentioned, in the Life with the Preterm Babies series will be on Thursday, October 27th, and will be about common winter illnesses, and we'll be welcoming Marianne Bracht from Mount Sinai Hospital in Toronto. So once again, we'd also like to thank, before we sign off, we'd like to thank Prolacta Bioscience for their support in making this webinar series possible. Once again, thanks to our great presenters and, of course, to the audience for joining us. And we hope to see you back here next month or in October. Bye, everyone.
Thank you.
Bye, thank you.